Well, good afternoon. My name is Professor John Deanfield, and I'm Senior Advisor to Public Health England for cardiovascular disease prevention, and also the Chief Medical Advisor to the ADD program that we're going to discuss today. Today, we're also joined by Claire Levermore, who's the Director of Operations for the Advancing Detection of Disease program. And Claire will be talking about the program and the opportunity to be one of the pilot centers to help establish this world-leading resource for health research. And we hope that this will be interesting and something that you may feel you're able to participate in. We have an hour for today's webinar session, which will take the format of a presentation by myself initially and subsequently by Claire. And then we're going to have a question and answer session at the end. So without any further ado, I'm going to give a brief introduction on the changing landscape for prevention and treatment and how that's affecting our thinking about healthcare. And then Claire will pick up on this and give you some more details about the ADD program and in particular the pilot program that we hope to start with. Next slide, please. Thank you. So when we think about our futures and our health, most of us would like to think that we're going to live to a ripe old age with excellent quality of life. But unfortunately, for many of us, that's not going to be the case. And the biggest determinant of that is the increasing prevalence of chronic diseases in the population: cardiovascular disease, diabetes, cerebrovascular disease, and other diseases such as cancer. So there's been a major shift in our thinking about healthcare that underpins this whole program, with a focus not just on better treatment of established disease, but increasingly important is the concept of preventing disease to delay first clinical events into later life. So let's start by looking at what we've been able to achieve in the last 150 years or so with healthcare. Well, the improvements in outcome have been spectacular. Since 1841, as you see on this slide, life expectancy in the UK, both for men and women, has pretty much doubled. Initially, that was because of reductions in childhood mortality, immunization, control of infectious diseases and the like. This was followed by improvements in nutrition, living standards, and population health in general. And more recently, big improvements in life expectancy have been achieved by better universal health care, better diagnosis, and importantly, better treatment of chronic diseases. Next slide, please. However, something very interesting has happened in the last decade or so. Next slide, please. Thank you. That progressive increase in life expectancy seems to have stalled in the population. So over the last 10 years or so, there's been almost no increase in life expectancy, both for men and for women. Now, what's the cause of this? Well, almost certainly the cause is the increasing prevalence of chronic diseases such as cardiovascular disease in the population. So these are having a huge impact on our ability to live longer, and not only live longer, but also live in good health. Next slide, please. Next slide, please. Thank you. Because you can see that chronic diseases are not only affecting life expectancy, but also affecting healthy life expectancy, the amount of time in our life we spend in good health rather than with a chronic disease. On the left, you see the proportion of life spent in good health in the UK has actually decreased, so that as we make people live longer, they're living longer, often with debilitating chronic diseases. Now, that's had another very important impact on population health. You can see on the right that these chronic diseases are not evenly distributed in the population, but increasingly prevalent in populations with lower socioeconomic status and more risk. So chronic diseases like heart disease, cancer, and respiratory disease not only affect our life expectancy and our wellness, but also contribute to health inequalities in the population. Next slide, please. Next slide, please. So if we look at what's happening and the challenge to us in terms of health management for our societies, We face an increasing burden in treating late-stage chronic diseases, but also the challenge is not to treat those diseases better alone, but to prevent them over the long preclinical period of our lives. Ischemic heart disease and stroke remain the world's biggest killers, accounting for 15.2 million deaths in the UK and around the world. And 5 diseases, cardiovascular disease, diabetes, cancer, chronic respiratory illnesses and mental health disorders, account for 70% of the disease burden and 86% of all deaths in the European area. In the UK, there's some really important and rather alarming statistics. Here you see that 2.5 million people are living with cancer in the UK. And by 2030, this figure will rise to about 4 million people. Equally alarming is the impact of dementia. The cost of dementia is expected to more than double from £26 billion in 2015 to 55 billion by 2040. The number of people living with diabetes is also increasing from 3.9 million in 2017 to almost 5 million people in 2035. And cardiovascular disease is going to have a huge impact on both admissions to hospital, costs, and quality of life. Next slide, please. Next slide, please. So what do we need to do to address these problems? Well, we need a shift towards sustaining health and preventing disease, rather than just waiting for clinical disease and managing it better. And we've got some huge opportunities to achieve this important goal. We can target patients better. We can identify individuals with early disease or even before any signs of disease who will benefit from early intervention, looking at new tests for those particular diseases, for example. We've got novel interventions, both in terms of better diagnosis, better behavioral change, and better treatments that have the ability to identify disease at an early stage and intervene early to try to alter the trajectory to future diseases. And important developments such as artificial intelligence and novel analytical techniques are really helping us with this goal. What we hope these two factors will achieve is an improvement in outcomes, sustaining health and preventing disease rather than treating late-stage patients with symptomatic and advanced disease alone. And that really is the philosophy underlying the Accelerating Detection of Disease program. So without any further ado, I'm going to turn over to my colleague Claire Livermore, who's Director of Operations for the Accelerating Detection of Disease program. And Claire's going to tell you about the program and the opportunity to be one of the pilot centers helping to establish the ADD program in the UK. We have a little bit of time for Claire's session, but we will also have time afterwards for the question and answer session, which we hope will be interesting and give you a chance to find out more about the program. So over to you, Claire.
Thank you very much, John. Next slide, please. So a little bit about this health research program and the enormous ambition of it, and the ambition which was set up based on everything that, as John has just said, around the looking at preventing chronic diseases. So the program is looking to invite 5 million people, age over 30 and above, from a wide, from all backgrounds, and ideally the cohort will be look at the UK population and be representative of the entire UK population. And it will be form a sort of nationwide community of volunteers. If we get the right people to join and we get an absolute diversity across the whole UK, then what we'll be able to build is the most detailed picture of the UK's health. And if we can do this, then just as John has mentioned, we'll help detect common diseases earlier and will help people to live healthier lives for longer. What we aim to do by starting the program at the age of 30 is to look at how people start to develop symptoms from the earliest onset and follow and to be able to follow people through and look at approaches both for looking at prevention and the ability to diagnose earlier and therefore to treat better. Next slide, please. So a little bit more about this program. So it's a huge collaboration which started with UK government funding via the Industry Strategy Challenge Fund, and from this it got 79 million, and we have further funds already allocated to support parts of this program. And this program will be a full collaboration between charities, academia, the NHS, life sciences industry, and together it will build this R&D platform for early detection and prevention research. On top of this funding that's already been granted, there will be an additional funding of around 160 million that will come from various companies and charities that will look to do further medical research and use this cohort to increase our awareness of prevention and early symptoms. Next slide, please. So this will give you an overview of how the program will operate. Essentially, we'll start with recruitment, so 5 million, and a big part of this challenge is the consent to data, to get rich source of data on participants, and this will be data that participants give themselves, but it will also be data linkages to NHS and other data. We will ask participants about their behaviour and their health, etc. So we will build a rich source of data from a questionnaire. We will collect measurements, physical measurements of participants, and this will change depending on the environment that our participant may be seen, whether that is in a setting at home or whether this is a setting in a health clinic. We will aim to collect blood, and again this was very likely from participants who will come in and face-to-face, and we will aim to collect saliva from participants that may never come in and have a face-to-face part of this programme. And that is the first part of this research program. The next phase will be using all of this data to calculate risk scores, and the long-term goal of this program will be to feed back these risk scores if a participant wishes to get this information. This is very much an opt-in, opt-out, and if you do not wish to have anything fed back, you will never have to. For those that do, we are looking, and this will be part of the ongoing development, to feedback scores which may help a person look at where they may be at risk for developing a disease, and helping consider ways to either prevent this or to change the course. So this feedback is very important, and it's part of what makes this program very different from other programs. And that'll be very much work in progress with you about how we feedback scores. We will aim to collect samples at potentially an annual basis, and again this is something we will work along with you on, and data linkages as many times as it's become appropriate to collect them. And we will also look about how we invite people to be part of new research and new studies that are linked to this cohort, and we may ask people to give more samples and to more data to be part of future research as well. Next slide, please. So just to say, the one thing that has been done to underpin how this program runs and everything about this program has been a huge amount of public involvement. And that has been from not only the planning on how we intend to invite people, but obviously all the materials that people may receive, whether they receive emails or letters, everything that we have done has been co-designed with the public. and we intend to carry on the entire life of this program in the same way. So we have established a co-design public group, and we're constantly building on this. And the idea is to build this program with public involvement at all stages, just to make sure that everything that we do and the way we set this up is done in collaboration and in agreement with how public will perceive us, and the best way of making sure we reach out to participants, future participants, from everything from the language we use, the amount of contact we have, the way that the IT is designed. Absolutely every part of this program will be done with the public involvement. Next slide, please. So, as you're already probably thinking, that 5 million people is an incredible large amount and will be the biggest undertaking in the world of this type. And so very importantly, we are starting with a pilot. Now, the pilot itself will be 5,000 people, so even the pilot will be fairly ambitious. And we very much need your help in working out the best way for delivering this pilot and what this pilot needs to test. So essentially, we're looking at the best way to invite people. And one of the reasons I'm talking on this webinar today is one way which has been identified is through the process of health checks. Now, I know that right now health checks are very, very challenging in this current environment. So we're looking to understand how we might be able to deliver this in the new year, but also what potential we have for at home as well. We very much want to test and pilot with you all the information that is given to people, both as part of the joining process, but also the explanations they're given about what data they will be supplying, about their physical measurements, about their questionnaire, etc. So we want to test almost all public-facing documents and materials. We need to understand whether people are agreeable to all the questions that we're going to be answering in the health and behavioural questionnaire. This is very important. The length of the questionnaire, the answers, whether people decide to do this or whether they stop halfway through. So we need to test as much about this questionnaire as possible. Obviously, we're looking to collect physical measurements, and we have to understand both at face-to-face contacts and at home what is possible to collect and how we can link that to people's health records. We're looking at the moment to collect almost very basic measurements to test out what is possible and the linkages. And then, of course, we want to test biological samples. So that will be both blood samples from the at-face meetings and saliva through the at-home kits. And we want to test not only whether this is acceptable to people, but whether we can get the samples from collection to where they will be stored. Next slide, please. So we really want to develop this pilot in partnership with the local authorities and through the NHS Check programme. We think that we would need to partner with at least 30 GP practices. That's obviously very much dependent on the size of the practice. And this is very flexible. We would ideally want to pilot with a wide range of covering the country as possible. So if we can cover from bottom to the top, that would be fantastic. And that's very much about uptake in different areas and just being able to pilot different systems through different GP practices. We very much want this to be working alongside you, understanding how we can effectively link what is the current NHS health check to what is our current pilot, understanding that there are future developments of both of these. We want to work with you to help design the main study. So this is very much working alongside you, understanding what is working and more importantly, what doesn't work. And we want to just make sure that we can effectively be able to run the main program in primary care settings, and we'll be using the pilot with you to understand the best way of doing this. So ideally, we would love you to volunteer to work with us. And what we'll do is once we get volunteers from practices or from areas, we will then sort of speak to you. I'll speak to you on an individual level and understand the best way of going forward, whether you pilot one arm of the study, maybe just writing to your patients at home, or whether you will be performing health checks in the sort of new year or spring, and we pilot that way. So there's lots of opportunity. You don't need to pilot everything. It would just be part of our program. And what we'd like to do is start the pilots from around March time. And we think that by starting March, bordering, if we say spring, there is more hope and chance that there'll be more patients coming into your practices. Next slide, please. I mean, ideally, what we're really looking to is link prevention programs together, so they're constantly learning off each other. So the NHS Health Check is an incredibly important program, which is running for over 40-year-olds at the moment, and it is representative. It does take part across the UK, and it's an incredibly useful tool for looking at prevention for cardiac diseases. Our program is looking to do the same thing. It's obviously looking for more chronic diseases, so more than cardiac. It's also looking to work across the UK. So what we really want is a learning tool that goes seamlessly from our program to NHS Health Check and back again, and understand how they can best work together, both for the pilot, but also for the main study and the main long-term goal over the next few years.